Thank you. And welcome everyone to week 3 of our 2026 ARCA Virtual Learning Institute. So wonderful for you all to be here. Really appreciate your participation, your questions, your engagement. It has been a full 3 weeks with some really great presentations, and we continue that today. Um, Today's presentation is Disability Advocacy and Counseling Practice, Cross-Cultural and Ethical Perspectives on Implementation and Interventions. Our presenters today are Dr. Daniel Balva and Dr. Daniel Page. We welcome both of you and thank you for being here. Dr. Balva is a licensed psychologist, a licensed mental health counselor, an NCC, and a CRC. And I think he's collecting a few more acronyms after his name. He's a staff psychologist in mental health and behavioral sciences clinic at the VA in West Palm Beach Medical Center in Florida. He earned his PhD in counseling psychology from the University of Georgia and his master's degree in clinical mental health and rehabilitation counseling from Florida International University. He's the past president of ARCA, woohoo, and a good friend. He is the past president also of Florida Association for Multicultural Counseling and Development. And that's when we actually met. Most recently, Daniel was selected as a council member for the Voice of the People global cohort under the leadership of Israel's President Isaac Herzog. In this role, he collaborates with international leaders from Jewish communities across 6 continents to address complex communal challenges, emphasizing advocacy, equity, and access across diverse global Jewish communities. He's passionate about disability education and awareness, global mental health, and capacity building. So glad you're here with us, Daniel. Thank you. And Dr. Daniel Page is the founder and CEO of Psyche Innovations, sorry about that, a digital mental health company that delivers evidence-based app platforms, live training sessions, workplace workshops, counseling services to organizations ranging from 10 to 10,000 in their staff. The Psyche Mental Health app is used in more than 90 countries. Daniel holds a PhD in psychology from the University of Queensland, with 14 peer-reviewed publications in journals, including BMC's Public Health and BMC's Medical Education. His research has contributed greatly to WHO, WHO, and UNICEF clinical guidelines on adolescent mental health. He was selected as an emerging global leader by the APA and has served as a panelist for South African Medical Research Council and the NBCC Foundation. He has also founded the Positive Youth Development Foundation, securing international grant funding from Australian and Japanese funders to deliver youth mental health programs in low resource South African communities. We're so glad both of you are here. Just have a few housekeeping items for our participants, just to remember that we are recording this and the recording will be put on our website at the most soon time that we can. And if you do have questions, we ask that you put them in the chat as they come up, and our presenters will address them as they move forward with the presentation. And with that, Daniel and Daniel, the floor is yours.
Thanks very much. Thank you for having us.
Yeah, thank you so much, Dr. Saccobenni and to ARCA. And it's wonderful to see, Dr. Saccobenni, your leadership with ARCA and just how far ARCA has come in this past year. So thank you so much for having us. And It's my honor. Good afternoon, everyone. To those of you here in the U.S., good evening to Daniel, who's joining us from South Africa. It's my honor to be here presenting alongside Dr. Page. This afternoon, we'll be speaking about disability advocacy and counseling practice, cross-cultural and ethical perspectives on implementation and interventions. And so for our presentation today, we have a few different learning objectives that we'll get through. So we'll be describing ethical, cultural, and contextual considerations relevant to disability advocacy and counseling practice. We'll compare how context, resources, and history shape advocacy and ethics across settings. We'll identify how evidence-based and technology-enabled approaches support advocacy. We'll discuss person-centered, strengths-based frameworks in advocacy-informed practice, and we'll also reflect on integrating ethics and advocacy into your professional work and client care. So by the end of this presentation, we'll all either be exhausted collectively or we'll be invigorated to go out and engage in advocacy, hopefully the latter. But just to share a little bit about our presentation overview, again, we'll be speaking about international declarations and historical overviews in terms of disability advocacy, as well as current inequities. We'll discuss some ethical and professional foundations through the CRCC, as well as the ACA. We'll also discuss disability advocacy across levels, looking at individual and client levels, community and institutional levels, policy and systemic levels. We'll take a look at levels between the US and South Africa. So we'll have a unique opportunity to kind of compare and see what disability advocacy looks like in both settings. And then we'll also discuss advocacy in action. So we'll take a look at the role and impact of technology, again, person-centered and strengths-based framework, as well as a reflection and practical application. And from there, we'll kind of conclude together. If anybody has any questions, we'll be happy to answer those again. Throughout the presentation, feel free to put those in the chat box and we will be sure to get to those. Just to share throughout the presentation in terms of language, so we'll be alternating between both person first and disability first language. So just as a refresher, when we're talking about person first language, that would be person with a disability. Right, it puts the person before the diagnosis. Used widely in clinical, medical, and educational settings, particularly here in the US. Right, it's encouraged by the ACA and CRCC. On the other hand, we'll also be using disability first language. Right, so a disabled person, for example. Again, it names disability as part of one's identity, not something to be hidden or distanced from. Right, it's widely preferred in the autistic, deaf, and blind communities. And so we'll also be kind of alternating between language there. But ultimately, just, the most important part, as we'll talk about advocacy and language too, is seeing what our clients prefer in terms of the language that we use with them, right? So ultimately, what's most important is the person in front of us and their own preferences. And so as we get started, we want to consider a brief reflection. Right, and for those of you who may be open to writing in the chat box, we want to invite each of you to think about, what comes up when you hear the word advocacy, right? So what comes to mind? And as you all, start to formulate, some thoughts, right? I'll share, when I hear the word advocacy, what comes to mind is kind of being on the forefront, right? Doing something to make a difference, right? Specifically, if it's for our clients, alongside our clients, if it's within our profession as well, right? So kind of doing something, being on the forefront, of that action, right? I wonder, Daniel, what comes up for you when you hear, when you think of the word advocacy?
Yeah, I think of it very broadly. The cheesy one I always jump to is save the whale. There was a big thing in South Africa, or South Africa is also, we are the country most affected by HIV and TB, tuberculosis. So often when I grew up in my early years of schooling and university, a lot of the advocacy stuff was kind of around those topics. And only later through training did I start to think about, oh, okay, well, you can really advocate for anything in different ways, which is, I guess, what we're going to touch on as we speak. But I mean, even when we were prepping this presentation, thinking about like what advocacy really means in the disability space, like it's broad. There's a lot to consider. So that's typically like what I kind of realized when we think about advocacy, and different approaches work for different people in different contexts, right?
So for different animals, as you mentioned as well too, right? So just like you mentioned, it can be incredibly broad, right? We see in the chat box as well that advocacy, you know, when thinking of the word advocacy, some mention thinking about legislation on an issue, right? Speaking up and educating, speaking on behalf of, being a proponent for changes that will benefit individuals and stakeholders, walking alongside and speaking with when possible versus only for. Right, so a lot of really great points, you know, that are coming up when we're thinking about the word advocacy. At that point, you know, I'd like to invite each of you to then think about, you know, what comes to mind when you hear the phrase disability advocacy. And for those of you who may be open to writing in the chat box, we'll love to hear those thoughts as well. All right, when you hear the term disability advocacy, what comes to mind there? And Daniel, I wonder for you, if you don't mind me asking, you know, what comes to mind when you hear that term?
Yeah, I mean, I guess I grew up with a disabled brother. So the kind of disability I thought of was more very like physical disabilities. And so that was kind of the space that we moved in. And my brother in some ways had a bit of a invisible disorder, even though it was physical, which comes with its own whole kettle of fish. And so for us, advocacy as a family, and then later on as a researcher, I wasn't really involved in like legislation change and policy change. And so for me, it was more about sort of implementing things, working in communities, working with people, you know, playing a game, normalizing being differently abled. So from an early age, I guess in some ways I was doing, you know, advocacy kind of stuff because, not to hop on too long, but disability visibility in South Africa is extremely low. People with disabilities are kind of like hidden away at home. The environments are really disabling. Just things like what do you guys call it? The sidewalk. Sidewalks in South Africa are just terrible. Like you can't really go on a wheelchair, and like the traffic lights, they don't like the time you have to cross the road is just so quick that even as an able-bodied, you know, young person, I kind of like hustle. So advocacy really could just be anything from advocating for, you know, ramps at buildings to spending quality time and making disability more visible. Those are the kind of things that I kind of entered into when I thought about it, and it kind of grew from there, I guess.
Absolutely, and I appreciate you sharing that, right? Even as you mentioned, you know, having done so much of that disability advocacy from a young age, not even recognizing it, right? And in the chat box, it looks like some had mentioned promoting clients for employment, ADA law, accommodations, qualifications, bringing disability forward as part of being a human. Advocacy for me means helping create space and tools to express needs and solve issues, and including disability as a consideration in decision-making and proactive inclusion of people with disabilities in many places when disabled people aren't often included, right? And so a lot of really wonderful considerations there, right? So appreciate each of you sharing. And we have one more, you know, reflection for all of you. And so we want to invite each of you to also start to think about when you consider disability advocacy and counseling practice, you know, what comes to mind for you there? So specifically in counseling practice as well. And we'll circle back to this reflection as well, you know, later on in this presentation. But before we kind of proceed, we do just want to share, you know, according to the American Mental Health Counselors Association, or AMCA, advocacy and counseling refers to actions taken by counselors to support and promote the rights, needs, and well-being of their clients. as well as to address systemic barriers that may impact them. It often involves working to ensure that clients have access to resources, services, and opportunities that foster personal growth and mental health. Additionally, advocacy can extend beyond individual clients to include broader efforts aimed at social justice, equity, and community improvement. Essentially, it's about being an ally and a champion for positive change, both on a personal and societal level. Right? And so as we think about that definition from AMCA and we think about these reflective questions, oftentimes the larger counseling profession doesn't typically include disability, within their definitions and considerations of advocacy. Right? And so kind of we're so grateful to be amongst the population here today, of ARCA members and attendees who really keep disability at the forefront. And with that being said, we want to continue to invite you to think about what disability advocacy looks like and could look like, and where you fit into disability advocacy within counseling practice as well. And so we'll circle back a little bit later to some of these reflections too. And so just very briefly, kind of as we'll consider an international, lens between the US and South Africa, we do want to acknowledge that there are international declarations and policies that have historically been put forth, right, between the United Nations and the World Health Organization, right? The most kind of relevant one being the CRPD, Convention on the Rights of Persons with Disabilities, right, which set forth globally accepted legal standards on disability rights and helps clarify the application of human rights principles to persons with disabilities. And so we'll keep some of these declarations and policies in mind as we continue to move forward as well. And so we won't spend too much time thinking about the historical overview of disability advocacy in the US, because many are already familiar with this. But we think about a few important threads that really helped build the disability rights movement, right? So we think about the independent living movement, right? From institutional care to community living, right? People with disabilities running their own services, having more of a say, having a say, right? Whereas previously that wasn't, something that was possible. Right? Think about education from exclusion to inclusion, right? IDEA, Section 504, and the right to free and appropriate public education. Think about accessibility, right? So from inaccessible by default to access by design, right? Think about just how far the US has come in terms of accessibility and how far we still have to go. Right? We think about anti-discrimination policies, right, and laws, so the ADA, Section 504, federal enforcement, right? And we also think about self-advocacy, from being spoken for to speaking for oneself, right? And that foundational principle of nothing about us without us, right? The phrase at the center of disability advocacy, in the US, right? And we'll continue to circle back to that phrase moving forward as well. Well, I realize we're kind of moving quickly through the US component, but I know that the South Africa consideration is incredibly meaningful and unique to so many of us. So Daniel, we'll love to hear, your perspective about current inequities in South Africa.
Thanks, Dan. Yeah, I mean, on paper, the policies and frameworks that we have when we think about mental health services is sort of on par, which would maybe be surprising in some ways. So after the apartheid regime fell in South Africa, we had this great opportunity to rewrite our constitution. And thankfully, the people at the time who were putting it together were the wise and forward thinking. So our constitution is actually one of the best ones and most forward thinking ones in the world, even still today. And along with that came progress over time, adopting things like the UN Convention on the Rights of Persons with Disabilities and the White Paper for the Rights of Persons with Disabilities and the Mental Health Care Act in 2002. But the thing I'll kind of stress in the story that I guess I'm telling is that there's quite a huge gap between what we know works and what we know we should be doing as society and in healthcare and education and social development services. But what actually happens is missing the mark. So you can sort of see the stats there that I'll talk you through, that 6% of South Africans live with a disability. But the reality is that most of those people are excluded from opportunities, work, education. So we're very far behind on what the targets of success should be and how they should look on sort of global benchmarks of people with disabilities in other countries. Obviously, we're a middle income country, not a high income country. But the issue, and I'll kind of talk about this more later, is that we're not going to solve this problem by just somehow training more mental health professional experts like yourself. The gap is too big. Even if we, quadrupled the number of professionals coming out, there just isn't enough money, there aren't enough resources, there aren't enough systems in place. And as an example, when I was building the Psyche Mental Health app, which is what our company does to help with psychoeducation, I spoke with the director of specialized hospitals in our province, or you guys might call it the state. And they openly admitted that they did an audit of all the hospitals and clinics and community care centers in the province to see how many healthcare professionals were there. And ultimately, this audit that they were supposed to make public, they didn't make public information or publicly available because they were too concerned that people would storm the institutions that had more provision of services because of this huge backlog of having one psychologist every 71,000 people. So, I mean, I'm speaking to the convert in terms of like how important these services are, but there just aren't enough of them. So we have to work with what policy says and how we should do it while appreciating the limitations of what we have and what we can actually do. But then we have a positive spin on this, not to sound too negative. We'll get there.
And it's an important consideration that you bring up there, Daniel, just understanding kind of the realities of so many of these inequities, as you mentioned, right? And yet kind of staying on the edge of our seat of kind of the positive spin, as you mentioned, right? But, as we think about that, we think about a quote, from Judy Heumann, who mentioned, change never happens at a pace we think it should. It happens over years of people joining together, strategizing, sharing, and pulling all the levers they possibly can. Gradually, excruciatingly slow, things start to happen. And then suddenly, seemingly out of the blue, something will tip, right? And so oftentimes it can feel like that sense of change through our advocacy isn't really making much movement or progress, right? And yet, as we come together slowly but surely, something will tip, right? And so we'll take a deep dive into some ethical considerations as it pertains to advocacy and accessibility as well. And we'll start to look at those ethical principles, in practice. But first and foremost, we'll think about the Code of Professional Ethics for Certified Rehabilitation Counselors through the CRCC, right? And so, of course, there's a whole code, right, that's not listed, on this slide, right? But just a few considerations related to advocacy, right? We think about C1, advocacy. So under that, there are attitudinal barriers, self-advocacy and guardianship, empowering the client, organizational and system advocacy, advocacy and consent, advocacy and confidentiality, areas of knowledge and competency, and knowledge of benefit systems. And so each of these are incredibly important, and relevant to what we'll be speaking about today. We won't go into too much detail about what each of these means, right? But we do want to highlight their value and importance. We also think about accessibility within the professional ethics code, right? And so barriers to service and barriers to community inclusion, right? And so kind of these obligations, under our code of ethics really allow us, with that familiarity to recognize barriers, empower clients, and engage systems, right? But we have to know what's mandated of us first, right? And so we'll explore just a few of these in a little bit more detail. And so some key points that came out of some of those different ethical considerations include recognizing and addressing attitudinal barriers, right? And so we do this in employment, education, healthcare, and community inclusion, right? And so we also want to recognize and understand stigma, stereotyping, and discrimination, right? If we can become familiar with the impact that that has, within the disability community and recognizing, the stigma, stereotyping, and discrimination within all of these different settings, right? Then we can start to address some of those attitudinal barriers, right? But first we have to become familiar with what's happening, right? We have to empower clients to self-advocate, right? So providing appropriate information to clients, parents, or guardians to facilitate their own advocacy actions whenever possible, right? And so again, part of that, as mentioning, is providing appropriate information. So first we have to equip ourselves with that information. Partner with client groups and community. So addressing environmental and systemic issues, right? Combating ableism and systems of oppression across policies, procedures, and practices. Oftentimes, this work is done in silos, right? And so we want to be very mindful. There are a lot of really wonderful disability groups and disability advocacy groups as well. And so how can we make sure that we're partnering with different organizations, with client groups and the larger community as well, so that everybody has an active say also in addressing these different systemic issues. We want to stay current on systems and laws, right? So we want to keep up with changes so that we can advocate effectively for clients, or also help them advocate for themselves, right? In a world where it can often seem like systems and laws may be changing, or new laws and systems are being implemented, right? We want to stay on top of that, especially as rehab counselors, right? Oftentimes our counseling colleagues, in the larger counseling profession, aren't as aware of different systems and laws, as it relates to the disability community. So it's important that we have that knowledge so we can also advocate in those spaces too. And again, ultimately, engaging in community collaboration. So to address systemic barriers for fair and equitable access, participation, and inclusion in the social, cultural, and economic life of the community, right? So how are we ensuring that we're engaged in collaborating with community partners and members of the disability community as well? So again, these are just some of the different parts of the code of ethics for CRCC. So we do want to be mindful of that. We'll also think about the American Counseling Association. So of course the ACA has their own code of ethics, right? But the ACA also has their own advocacy competencies, right? And these are skills, knowledge, and behaviors that counselors need to address systemic barriers facing students, clients, client groups, or whole populations, right? And so there are two different components to these advocacy competencies. One being the extent of client involvement in advocacy. So really questioning and considering, are we advocating with the client at the table, or are we advocating on their behalf when they're not able to be present at the table, right? Each of these play an important role and serve an important function, right? But they do call for different skills and knowledge of when to engage in both types of advocacy, right? And the advocacy competencies also discuss different levels of advocacy intervention, right? And so whether this be the individual client level, school or community level, or the wider public arena, right? And so we want to think about in what setting are we engaging in advocacy and what would be most important, and most effective given whatever type of concern we're trying to address here. And both dimensions intersect across 6 domains of advocacy, right? So empowerment, client advocacy, community collaboration, systems advocacy, collective action, and social political advocacy. And last but not least, we want to think about between these different ethical codes, and advocacy competencies, where do our values end and where do the values of our clients begin? Right, so the ACA code of ethics makes sure to note that counselors are aware of and avoid imposing their own values, attitudes, beliefs, and behaviors, right? And so professional values are an important way of living out an ethical commitment, right? But we really want to be mindful of where our personal values are coming into play and where we need to keep those at the door, right? And focus on our professional values, right? So there are some questions that we want to consider, right? Where is the overlap, right? So personal value may be, advocacy is incredibly important to me, right? But now, how does that fit in, and where does that overlap sit with our professional values, right? In what way are we advocating, right? Are we advocating on behalf of a client because we perceive that to be an important value, versus is that the value of what our client is wanting, right? So we also want to think about what is important to us as counselors and why, right? So getting to the root of what are our personal values and our professional values. And where does advocacy fit within all of that, right? So inside those sets of values, where does advocacy live, right? And more so leaning towards the professional values, right? And considering, again, not wanting to blur our own personal values with those professional ones. And so with all of that, we kind of want to consider each of those different points, as we'll start to talk about different ways in which advocacy can look and has looked as well.
Right. My turn. So I'll be talking about disability advocacy across levels of practice and cultural settings. And again, as we mentioned before, please pop some questions in the chat as we're going. If you have some the questions you'd like us to engage with, and Daniel, feel free to ask follow-up questions as I'm going to tease out more helpful things to say. Right. So at the kind of most intimate level, we obviously have individual or client level. So advocacy at this level removes barriers between the person and the support they need. So really, there's 4 practical moves that can be done. So recognizing barriers that you can't see but are present, right? So clients might arrive carrying barriers from family or school or their providers, and the daily inaccessibility of buildings and services that are really not built for them. Daniel, you can actually, when we were making the presentation, you had a great example of this that you encountered. Would you feel free to share?
So, a while back, I was working in the sector of vocational evaluations. And so with the company that I was working for, they would send us to different locations across the state of Florida. And so it was always a surprise to kind of figure out where we'd be doing an evaluation. And so it was always a new environment and a new setting, a new office space. And so one of the office spaces that I was sent to actually didn't have a bathroom on the ground floor. And so doing an evaluation with a client who was using a wheelchair, right, it was an inaccessible environment, right, in terms of just not having access to a bathroom. In another environment that we had, the bathroom door was incredibly difficult to open, right? And so these are some important considerations thinking about, advocating at the individual or client level, right? This was a one-time evaluation. The client wouldn't really be working with our organization anymore, right? They'd be returning to their voc rehab counselor. And so kind of advocating on behalf of clients, right? Going back to the organization and saying, hey, these specific sites that they have us doing these evaluations at are incredibly inaccessible, right? So kind of thinking about at that individual client level, how might we be able to engage in advocacy there?
Yeah, and how we in our work or the environments might disable people in not being able to function at their optimal level, right? I mean, that's what disability is all really about. Then obviously on an individual level, there's adapting interventions. So I use the term intervention quite broadly there, from treatment to sort of promotion, prevention kind of work. And appreciating, that it's the intervention that needs to be changed and built for the person, not the other way around. And so my framing is to use a sort of like strengths-based approach and move away from just a deficit model. When I started researching interventions and trying to make change in South Africa with youth groups in the disability space quite broadly, but mostly congenital disabilities. And there was so much work that was being done on the deficits. What were the challenges that they had and the issues that they had? And you'd go do an interview with a young person, and I would ask them, hey, well, what are the things that you really enjoy, with these positively framed questions? What could we do to make life easier or better for you? And people who were disabled and in chairs, they couldn't walk, they would say things like, oh, I just want to walk, and sort of like wishful thinking things. But what we actually found is, when we dug deeper into it, the things that really made their lives good and livable and give them life satisfaction and joy was not necessarily taking away some of the bad things. It was actually adding the good things, the strength-based stuff. And the reality then became that we were looking for these opportunities to be engaged in sport or hobbies or, whatever, and they were very limited. I mean, they were limited for able-bodied people, so people with special needs were really being left behind. So a lot of the work that can be done there is really just adapting what we have for those populations. Then obviously there's supporting self-advocacy, equipping clients and guardians with the information to advocate for themselves. So a lot of the work can just be psychoeducational in nature. So an example from my own work, I went to a big HIV and AIDS conference in South Africa when I was just coming out of undergrad. And there was a big famous researcher, I can't remember her name, but that's actually kind of important in the story. And she was saying that we don't need more people to recreate the wheel. Like, we don't need the Daniel Page disability program. We need people to take what exists and make them better, improve the evidence base, refine it. And that was kind of the thinking that I, started my PhD with, was we see this need of needing more pro-social, psychoeducational, and physically active games and opportunities for young people with disabilities, but there just weren't many. So my supervisor developed the Life Matters program, which was a CBT-based, positive psychology-based, and sports psychology. Those three things kind of squished together into a 10-session program. So, I reviewed the research and identified ways that we could adapt this intervention for people with with a wide range of abilities. Some people were paraplegic, some of them were quadriplegic, some of them had learning disabilities. So we had to kind of go to the schools and interact with people, and we had to kind of be quite pragmatic and see, okay, well, what activities and games and stuff are out there in the literature that people had come up with. And we kind of made a manual and go, okay, well, if you show up on the day and this is who you've got, maybe we have games that just use hands, because there's somebody in a chair. Then you've got to be really creative when somebody's a quadriplegic. Okay, well, how do we incorporate them into games and these activities? And I think sometimes it sounds very daunting to do that kind of work, especially if you haven't done it before. But I think you go in with an open mind, and you kind of figure things out as you go. And I'll say this is one last thing on the slide. We use a train the trainer model, which I'll talk more about later. But one of the young ladies who we trained up, she went to do her first implementation at this special needs school. She's actually the blonde lady at the bottom there. And she was so nervous that she was going to say the wrong thing or do the wrong thing. And I said, well, ultimately you will, like everyone makes mistakes, right? So then you just kind of roll with it. And I saw her after the first session, and she slapped her forehead and said, I was, saying like, oh, let's all jump up and go do this activity over there. And, some people were in chairs, and she's like, oh, I'm telling people to jump up and, walk over somewhere using language that obviously wasn't, ideal. But, I asked her, well, what happened then? She was just like, oh, whoops, I corrected my language and moved on, and people were fine with that. And that's kind of the reality with these individual implementations. It's like what happens on policy, and then what the ideas of the system should be, and then how things actually happen one-on-one or small groups, you have to be flexible. You have to kind of adapt as you go. Because at a policy level, you can say things so neatly and perfectly, but how things work in the real world is often a bit different. Right, so then we have the community or institutional level. So one counselor reaches one client if it's one-on-one work, not group-based, but a trained community kind of reaches a generation. You can kind of see the cascading butterfly effect or network effect of using train-the-trainer models in that community-led advocacy is really where there's quite a lot of leverage to make impact. So councillors here hold something that most of the broadening, you as councillors, have something that most of the broader counselling field does not have, and that's disability expertise. And sharing it through training and partnerships and showing up in rooms where disability is left out of the conversation is institutional advocacy in practice. And I think there's often sort of like an imposter syndrome kind of effect when people go like, oh, who can adapt this intervention, or who can come up with a way to advocate. And I think a lot of times we kind of looking for somebody else. Oh, I don't know if I'm the right person, if I'm ready, and we forget how much we know and how much we can do and how much we can provide to people. And I think there's a self-deception that happens the more you study mental health and the more you educate in psychology, that you think, oh, I don't actually know that much, which is kind of the curse of being more and more educated. You realize how dumb you really are. But I say this in a positive way, in that you do know a lot, and you can find interventions that work. You can reach out to researchers or clinicians or whatever in your network and say, hey, let's come up with something where we train people on sort of like a basic level, and then it kind of has this cascading effect outward. And think about that as you kind of climb higher and higher in your up the ladder in your expertise and experience as you're training. And this is basically what sort of my experience was through my work. Is initially I was running the interventions and seeing the impact with young people. We worked with university students, and we worked in low resource, predominantly Black communities, and you guys would call them mixed race communities and disability communities. But the real leverage I found was when I started training university students in psychology and sports science, and some of them from engineering and all sorts of backgrounds to implement these trainings, because I can train 10 people and they can then each go out and run the intervention with 10 people. And I think that's where a lot of our leverage exists in making impact. But this is my bias to advocacy work. I'm very intervention focused, but the thinking behind it can be applied really across any type of advocacy work. And the quote at the bottom there really kind of illustrates that whole idea of not stepping back, and leaning more into it. If not us, then who? And the counsellors in this audience hold disability expertise that the broader field doesn't. So sprinkle it, share your work and the things that you know, and drive impact that way. Right, so I kind of spoke about this a little bit earlier on a policy or system level. So policy without implementation isn't protection, it's a promise. And if you know anything about South African politics, you know there's a lot of promises made and very little delivery, which is a huge frustration for us. And unfortunately, what happens a lot in low and middle income countries is we take ideas from developed countries, America being one of them, and we implement it here because on paper it sounds smart and it makes sense. But then the implementation is the thing that kind of falls through and fails. So an example is Life Esedimeni. So between 2015 and 2017, the Gauteng, which is a province or state, health department made a decision to sort of cancel a long-term contract with a psychiatric provider. And basically what happened is 1,700 patients were essentially transferred to under-resourced NGOs and NPOs. And what happened was 144 of those people died, 1,400 of them were exposed to trauma and torture and serious health violation. And 44 of them just disappeared. We have no idea what happened to them. It just went missing. And the bitter detail, which I'll say slowly, is that this decision was framed in the language of the Mental Health Care Act, which was, one of our key pieces of legislation. And it was supposed to be community-based. It was supposed to be less restrictive care. And on paper, the policy was right, but the execution is ultimately what killed people. So, what is a counselor's role at a systems level? It's really to know what some of the protections are, what resources are out there, what services are out there, what legal protections are there for people with disabilities, and then holding the system to them. And then, of course, bearing witness when the implementation potentially fails, and constantly trying to iterate and improve on these systems through working with the healthcare departments and government and people in boots on the ground, and trying to actually do the work. I'm trying to put in all these American terms, boots on the ground. I'm doing my best. Right, so thank you for laughing, Daniel. I appreciate it. So what is the kind of difference between the United States and South Africa? There's obviously vastly different histories, and different scaffolding and different, approaches that led to where we are today. But if you zoom out a little bit, the policies and the ideas and the systems for how we implement things are very similar. We have, much of a muchness in terms of our ideas around how we should do it. And that's equally true for community level, and it's true on an individual level as well. Of course, the complexity and the variety and the quality of services in America, or the USA, is of a much higher standard, but the implementation challenges are the same. The statistics in terms of the treatment gaps and psychoeducation levels and employment levels, and they're both not as good as they should be. And I think that's the thing that we kind of have to keep stressing, is that advocacy is important at all these levels. It's not like if we just get it right on a policy level, then it'll just trickle down and we'll all be bathing in the sunlight of perfection. Work has to be constantly done and iterated on all levels to really see that difference come through. Right, so I'll move on, and as I said, please throw some questions in the chat. I'd love to engage with them. So the next part we'll be going through is advocacy in action. So as I already mentioned, or I think the bio mentioned at the beginning, I run a digital mental health company. So my expertise is a little bit in the technology space. And benefit of technology, and to arrest fears of where I'm going with this, technology is, it shouldn't and won't replace counselors. Technology used well is about extending counselors' reach and the quality of that care, and reducing admin and burden, and being able to reach more people effectively and give them support outside of that very high quality one-on-one service or group-based service that they're providing. And technology in mental health shouldn't be a swear word. It should be something that we're kind of all working together to promote. And there's three kind of things that it can do or should do. And one of them is lowering barriers to access. With that huge gap in service provision of mental health practitioners, it's particularly bad for young people in a country where there's no safe public transport. They literally can't get anywhere. If you're rural, you live in the sticks on some farm, no chance. Right? So technology has a way of getting around some of those language barriers. I mean, we have 13 official languages in South Africa. Trying to find a healthcare provider or services that's in your language is tough. And that's where there are opportunities to leverage technology to overcome some of those barriers. It also can help build capacity where it counts, train the trainer models, codified protocols, digital workflows that multiply expertise. So it could be simple things from, and you might not agree with using all these different tools, but one can be a tool that transcribes your session so that it reduces that sort of admin. And another one Daniel was telling me about yesterday is a Harvard professor who creates these online digital trainings to upskill lay people and mental health practitioners in different evidence-based skills and tools so that they can provide services in low-income countries and communities. I think he works a lot in, Vikram Patel works a lot in India based on what Daniel was telling me about. So you know, there's so many opportunities there. And that's essentially what I was trying to do with my work is take what we know works, you know, not recreating the wheel. Psychoeducation, goal setting, journaling, learning things like meditation and positive self-talk and whatever, and putting in the hands of as many people as possible. And that's where you can kind of find what works for you. Do a little bit of research. What resources are out there that make sense for your modality and your approach and your age group and your, you know, the people that you serve. A hammer often isn't the right tool. Sometimes it's a screwdriver, right? But if you know what's out there, you can be more effective with it. So, Danny, we're trying to get through. Sorry, go for it.
Just add kind of, as we spoke about the ethical codes previously as well, right? So the ACA Code of Ethics and CRCC, right? They also both touch on, you know, important considerations for technology use as well, right? So we do want to be mindful of that too, right? And yet, kind of as Daniel's showing us, there are also some unique ways and opportunities that we can also use technology, you know, in terms of advocacy, in terms of larger reach as well, right? We do want to be mindful of kind of those ethical considerations that kind of in the US that we have for us as rehab counselors too.
Yeah, exactly. And I think there are tools and resources that are built not having those in mind, and there are some that are. So, I mean, I guess it does put a little bit of a work on the provider to kind of do their own homework, but that is a form of advocacy, is finding the approach that works for you. And I spoke to Daniel about this, and I used the Save the Whale example at the beginning. But I think we can find where we feel we have the most competence and it fits our style and approach. Some people want to work at the policy level, some community, some individual. An individual could be using digital tools or, you know, creating a resource list of numbers or organizations to visit or whatever. There's an endless list of things that can be done to make an impact. Right, so person-centered and strength-based frameworks. As I said earlier, the deficit model asks us what is wrong with the person. The strength model asks what is strong in the person and what is wrong with the environment around them. How is the environment disabling them? So this is obviously a stance, not necessarily a technique. And obviously you use a holistic approach, but it essentially means starting with what the person can do and their values and wants, and not focusing too much on the diagnosis. Treating the person as the expert on their own life. They know their context and the challenges that they have better than we do, obviously. Locating the person in the interaction between the person and the environment, not in the person. So yeah, where does the problem lie? And then co-designing interventions or treatment or care, so that they're delivered appropriately. And this really kind of goes back to the quote that we had earlier, that nothing about us without us. And that's when interventions or services are better. I mean, South Africa, as an example, we build special needs schools. That's what we call them. That's what you guys call them. Schools for people with disabilities. And they've built a whole bunch of them without a ramp to get into the building. So if you're in a chair, tough. No, you know what I mean? So even when they tried to do things correctly, they just didn't consult people and have a mindful approach to what they were doing. Right. So in terms of reflection and practical application, where in your work is the implementation gap? You know, is it at the individual level? You know, who is the client you're working with right now? Whose support is being blocked by something other than their disability? You know, what's the barrier, and what's one thing you could do this month to sort of push back against those barriers or advocate in the individual space? And I'll go through community and policy, but that's kind of the overarching thing, getting you guys to think about, you know, in your community or your institution, could you upskill a partner? Could you create a program? You know, could you bring an expert in that, you know, has a great way of solving or approaching a barrier or challenge that you have in your setting? And then can you take your expertise and multiply it? And then obviously on a policy level, you know, what protections exist for your clients that they don't know about? And you know, what are you going to do to make sure that those protections actually reach them? I often say a tool's not very useful if you can't reach it and you can't use it, right? Dan, is there something you want to jump in and say before we start wrapping up with some of the resources?
Yeah, it just kind of in terms of timing, we could jump into those. So far, so good.
Cool. So we'll share this, well, I assume this presentation will share with you afterwards. But obviously there's tons of different resources that one can look into, from job networks to those policy documents that we looked at, to advocacy groups like Section 27 in South Africa, mental health and wellness groups in the disability space or more broadly, and then digital tools from apps to evidence-based intervention manuals. There's and those ethical codes that we talked about earlier. These are all great resources that you can use and familiarize yourself with, or keep on hand, or signpost people to make a big impact in their lives. So as we kind of wrap up, we have one sort of final reflection, one thought to sort of take away and sort of sit with. So the takeaway is the work does not necessarily have to be in writing new policy. It could be in making the policy we already actually have reach the people it was written for. You know, you hold disability expertise that the broader counseling field doesn't have, and often you are uniquely close to the problem. So, you know, use what you have in a way that feels comfortable to you. So the question really is, where do you fit into this disability advocacy practice? You're probably already doing disability advocacy work. And what is one conversation you might like to have this month with a client or a colleague or assistant to start closing that gap? I don't know if we have much time for questions because we waffled so much. But if they do come through, we'd like to hit as many of them as we can. But otherwise, I'd just like to say thank you on behalf of myself, and I'm sure Daniel's obviously very grateful for being here too. But he can say that himself.
Thanks so much.
Thank you so much. I didn't see any questions in the chat. We did have a comment, you know, walk a mile in my shoes to get that perspective. And what really comes up for me is advocacy can happen every day, and we don't have to have a special occasion to make that happen. And I think your experiences and what you shared really brings light to that. We don't have to find that special thing, that marching orders. We can do it every day, and it can lead up to those larger policy changes.
Yeah, exactly. We all have power to make change in the work that we do, at every level of impact that we were talking about.
Wow. Thank you very much. I'd like to thank our presenters today, both in Florida and in South Africa. We are definitely global today. Appreciate all our participants today too, and look forward to seeing you tomorrow for our next presentation. Have a wonderful evening, folks. Take care.
Thank you
Thank
so
you.
much.
Take care.